Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Hello, I am Andres Capizzano from the University of Michigan. I will be talking today on neuroimaging of demyelinating diseases, multiple sclerosis, and neuromyelitis optica spectrum disorder. I have no disclosures. My objectives are to revise neuroimaging findings in multiple sclerosis and NMO. If we compare multiple sclerosis on the left with NMO on the right, in the case of multiple sclerosis, the primordial lesion is the immune attack against myelin, which is a component of oligodendrocytes, while in NMO, it is an astrocytopathy. MS is characterized by the presence of oligochronal bands that indicate intrathecal production of antibodies, while in NMO, there are characteristic antibodies, most commonly anti-aquaporin 4 or anti-MOG, that are part of the diagnostic criteria of the disease. In multiple sclerosis, the imaging features include perivenular white matter inflammation, which is manifested as the Dawson fingers and central vein sign that I'm going to show later. NMO is characterized by the more aggressive optic neuritis and longitudinal myelitis in comparison to MS. Finally, in multiple sclerosis, the relapsing remitting type is the most common presentation. In NMO, there is a more severe prognosis, and also patients respond different to treatment. Therefore, it is important to make this distinction. Multiple sclerosis imaging. There is preferential involvement of the periventricular white matter, particularly in the corpus callosum, also the brachium pontis, optic nerves, and the spinal cord. Most plaques occur next to the subependymal veins, 50% in periventricular distribution. The periaqueductal region and the floor of the fourth ventricle are also frequently involved. Active plaques show contrast enhancement and restricted diffusion because of the presence of intramyelinic edema. This is an example of the so-called Dawson fingers in multiple sclerosis in FLAIR images showing the characteristic perpendicular orientation of the lesions in reference to the ependymal surface. Optic neuritis in multiple sclerosis is typically seen as avid enhancement and T2 hyperintensity of the optic nerves. In this case, on the left side, on this fat-saturated post-contrast T1, while on the coronal images, we can also see the enhancement at the level of the left optic canal and the T2 hyperintensity of the left optic nerve in comparison to the normal right optic nerve. The myelitis of multiple sclerosis is typically short, about 1 vertebral body in extension, and it's associated with T2 hyperintensity and expansion of the cord in the acute phase. There are more specific lesions associated with multiple sclerosis that are incorporated in the most recent 2024 updated version of the McDonald criteria, which are the central vein sign and the paramagnetic rim sign. The central vein sign is nicely shown in this example, where we have a left prefrontal white matter FLAIR hyperintense enhancing lesion that on the susceptibility weighted image show the presence of a vein in the center of the lesion. This feature represents the perivenular distribution of the inflammatory process, which is characteristic of the pathophysiology of multiple sclerosis. The other sign is the paramagnetic rim sign, which is appreciated on the susceptibility weighted image, as you can see within the red circle, that matches the location of this flare hyperintense lesion in the right frontal white matter, and this is due to the accumulation of hemosiderin in the periphery of the lesion, where the macrophages that are part of the histologic manifestation of multiple sclerosis accumulate at the edge of the lesion, and that produces the paramagnetic rim sign. Moving on to NMO, the optic neuritis is more severe, can be bilateral. The myelitis is longitudinally extensive, involving 3 or more vertebral segments. Lesions of the area postrema in the medulla with intractable hiccup, nausea, and vomiting are highly specific, although rare. Diencephalic lesions, especially in the hypothalamus, are commonly bilateral and also quite suggestive of NMO. There is also a relatively uncommon but a specific type of lesion in the posterior corpus callosum called splenial bridge lesion. And a more common feature is the so-called marble or edematous look that is nicely shown in this example of this right temporal lobe, quite fluffy, ill-defined hyperintensity corresponding to a patient with anti-aquaporin 4 positive NMO. This is a different example of a 19-year-old young patient with anti-aquaporin 4 antibody positive NMO, where we can see in the flare images a very symmetric area of hyperintensity and the ventral hypothalamus with no associated enhancement or restricted diffusion. The optic neuritis in NMO, as I mentioned before, tends to be more aggressive, like in this case of bilateral extensive enhancement of both optic nerves and T2 hyperintensity. This was an example of NMO in pregnancy. We couldn't give gadolinium, so we had to rely on the T2 hyperintensity on these fat-saturated images showing the hyperintensity of the optic nerves in comparison to the normal white matter signal. The myelitis in NMO is more extensive, as we said, 3 or more vertebral bodies in extension with associated contrast enhancement, swelling of the cord, and the so-called T2 bright spotted cord lesion, which is manifested as very T2 hyperintense lesions within the spinal cord. In summary, multiple sclerosis is characterized by the presence of dozen fingers that follow the distribution of the subependymal veins, the central vein and the paramagnetic rim signs that are visualized on susceptibility weighted images, more focal optic neuritis, and short segment myelitis. T1 black holes are a very well-known feature of chronic demyelination, frequent involvement of the corpus callosum, frequent presence of juxtacortical lesions, and involvement of the cerebellar peduncles. In Neuromyelitis Optica Spectrum Disorder, the white matter lesions tend to be more fuzzy with ill-defined borders, and this is what we call the marble look of the NMO lesions. Optic neuritis is more aggressive, extensive, frequently bilateral. The same thing can be said of the myelitis, which is long segment characteristically. The presence of the T2 bright spotted cord lesions is also a feature of NMO. The arching bridge splenium lesion as well. The third ventricular lesion is suggestive of NMO as well. Lesions of the area postrema are specific but infrequent. And finally, there is also reports of meningeal enhancement in NMO. And with that, thank you very much for your attention, and I'll be happy to answer questions in my email.